Good evening, everyone, and welcome to the webinar on clinical utility of liquid biopsy in NSCLC. It gives me great pleasure to invite our moderator, Dr. Vinay Bhatia, Consultant Molecular Biology, Oncquest Laboratories, Gurugram, to give the welcome address and overview. Over to you, ma'am.
Good evening, everyone. Myself, Dr. Vinay Bhatia, on behalf of Oncquest team, would like to welcome you all in today's webinar on the topic clinical utility of liquid biopsy in non-small cell lung cancer. Of late, the applications of liquid biopsy for the diagnosis and treatment decision of non-small cell lung cancer patients are increasing. Compared to invasive tissue biopsy, the minimal invasiveness and the low cost of liquid biopsy allow repeatable evaluations of cancer patients, so making it a very useful tool in the clinical practice. Liquid biopsy refers to the analysis of any tumor-derived material circulating in the blood or any other body fluid. So this concept is particularly relevant in lung cancer as the tumor is often difficult to reach and may need an invasive and potentially harmful procedure. Moreover, the multitude of anti-cancer drugs and their sequential use underline the importance of conducting an iterative assessment of tumor biology. So liquid biopsies can non-invasively detect any targetable genomic alteration and guide corresponding targeted therapy. In addition to monitoring response to treatment and exploring the genetic changes at resistance, inter and intra-tumor heterogeneity as well. So in short, liquid biopsy has the potential to help manage non-small cell lung cancer throughout all stages of lung cancer, like screening, minimal residual disease, detection to guide adjuvant treatment, early detection of relapse, systemic treatment initiation and monitoring of response, and finally, resistance genotyping. So this webinar will surely enlighten us with the potential of liquid biopsy in the area of lung cancer, with a particular focus on cell-free DNA and circulatory tumor cells. We'll get to know their respective applications in potential selection and monitoring through targeted therapy, as well as immune checkpoint inhibitors. So the first speaker of the day is Dr. Aditya Morley. Dr. Morley is and hemat-oncologist, BMT physician from Esther Hospital, Bangalore. Dr. Morley would be talking on the clinical implication of liquid biopsy in lung cancer. Over to you, Dr. Morley.
Thank you, Dr. Vinay, for such a kind introduction. I will just take a minute before I share my screen. So essentially, over the next 20 odd minutes, I have tried to restrict myself to predominantly talking about the clinical implications, and if we do in fact end up detecting a mutation, how do we go ahead and how do we treat our patients? But the bulk of this talk is, as Dr. Vinay Bhatia put it very clearly, the bulk of the talk and the bulk of everything is going to be focused upon the role of liquid biopsy and how it has evolved over the past few years of clinical practice. I mean, I think I would have attended the World Lung Cancer Congress in Denver about 7-8 years ago. At that point of time, everybody was talking about CTCs and what is the best machine to use and things like that. Now, liquid biopsy has well and truly entered the domain of clinical practice, and it is incumbent upon us to use this for the benefit of our patients. So essentially, liquid biopsies have a role at prognosis, at diagnosis, and in terms of monitoring. What all are the types of liquid biopsies that we can look at? There is circulating tumor cells, there are circulating DNA or ctDNA, there are exosomes which can be monitored, and there are tumor educated platelets which can be detected from the bloodstream, and these can be utilized for diagnosis and prognosis. So if we look at the current clinical indications as on date for liquid biopsy in non-small cell lung cancer, the primary one would be for driver mutation testing and diagnosis. And although tissue is almost no longer such a big issue, Still, every often, I mean, very often, at least especially in tier 2 cities where the ability to get good EBUS based tissue is not all that great. Tissue may be insufficient to run complicated molecular testing, and especially if we try and do piecemeal testing. So the earlier prevailing concept was, let us do a piecemeal testing, let us do a reflex testing. First test for EGFR. If EGFR is negative, then do a ALK, then do a ROS1 and things like that. And this kind of a reflex testing also uses up a lot more of precious tissue. So at some point of time we would end up running out of tissue, and in such a scenario, liquid biopsy is a very reasonable way at looking at diagnosis. For example, if a liquid biopsy picks up a EGFR mutation and we don't have enough tissue to confirm it on a tissue based testing, that is good enough reason for us to start targeted TKIs in this kind of scenario. The earliest use of liquid biopsy in non-small cell lung cancer was basically in the identification of resistance pathways after first line therapy. So EGFR T790M mutations, I remember, especially because AstraZeneca was offering this coupons, and it became so easy for us to test as many patients of ours as possible. So if we had a patient who progressed on first generation TKIs, the easiest way, and at that time getting fresh tissue was, as see, first biopsy itself is difficult in our setting. If we want to do a second biopsy and subsequent biopsies at progression to identify resistance pathways like T79, T790M mutation, that becomes a huge challenge for our setting. And in such a scenario, liquid biopsy to assess the T790M mutation itself was a very big boon. So I think at least in most of our clinical practices, this was the first one which came to everyday clinical use. Technology has gone to such an extent that we can do PDL1 testing, and there are companies which are offering PDL1 testing on circulating tumor cell based platforms. So we can use CTCs to check for PDL1 levels also, which can potentially guide us towards the use of immunotherapy if we have a problem with tissue in our patients with non-small cell lung cancer. So what are the primary actionable driver mutations which can be identified? So if we look at any standard liquid biopsy lung panel, I think the main mutations which we are able to which we are able to identify with a liquid biopsy would be EGFR, BRAF, MET, RET, and KRAS. But if you look at a standard panel, apart from these actionable driver mutations, we get a whole host of other non-actionable but potentially, sometime in the future, which we can take an action on. So things like, FGFR1, FGFR2, because we have these inhibitors with us in clinical practice, although they have been approved for different other indications. If we do pick up a FGFR2 mutation, it can be used in a later line of treatment. Same goes with, things like IDH1, IDH2. If we have patients who have progressed on immunotherapy, in spite of having a very high PDL1 mutation, then we know that, if we are able to identify JAK pathway mutations, then that can give us a reason to try alternative therapies. So the first and the most important mutation is the EGFR driver mutation. EGFR mutation epidemiology is somewhat like this. It is more common in never smokers and in females and in Asians. If you can look at this cartoon over here, you see that, through all of these exons, exon 18, 19, 20, 21, all of these sort of encompass the whole gamut of EGFR mutation. So it is very important to identify the specific EGFR mutation, whether we have a exon 19 deletion, whether we have a L858R translocation exon 21, or whether we have a exon 20 insertion mutation. So all of these do end up guiding our therapies. So we have a first generation TKI, we have a second generation TKI, and a third generation TKI. The first generation TKI, this slide basically talks about the data of all the first generation TKIs, we have had first generation TKIs. I think for the better part of last decade itself, we have had first generation TKIs. My own parent institute, Dr. Robert Lewis, has published data on this way ago in using Jeftinib. And if we use a first generation TKI like Jeftinib in first line setting, there is a reasonable improvement in overall survival, with overall survivals basically ranging from about 6 months to about 20 months also. So Dr. Vanita Naronia's team published the biggest paper with Jeftinib use in first line EGFR mutant non-small cell lung cancer, and they were able to show overall survival of nearly 21 months. Then come the newer crits on the block. There was the Archer 1050 trial, which looked at dacometinib. In this trial, dacometinib was used at a dose of 45 milligram once daily, and the comparator arm was a first generation TKI. So in the evolution of the we have now moved on from first generation to second and later generation TKIs. First treatment naive patients. The primary looked at offline, which is the generation EGFR TKI, and here the comparator was either Jeftinib or erlotinib. Again, in this the primary efficacy, the primary outcome which was assessed was progression-free survival. This slide talks about inclusion exclusion criteria. So I think the important thing to note is that Archer had a fairly large number of Asian patients in its study, but these Asian patients were predominantly from East Asia, from Japan and from South Korea. Patients with brain metastasis were excluded in this trial. This trial was primarily for first-line treatment setting. With regards to the FLORA trial, this trial also included patients who had EGFR exon 19 or exon 21 mutation, and patients with CNS metastasis which is stable were also included here. We can see that the progression-free survival as per the KM curves are absolutely fantastic. They were great when we talked about the dacometinib, which was the Archer trial. They were even better when we talked about osimertinib, which is the FLORA trial. In fact, the median progression-free survival, if we use a third generation TKI today, is going to be nearly 18 months, a year and a half of PFS in first line for patients with stage 4 non-small cell lung cancer. And this is something which was almost unheard of when people were even trying to identify driver mutations in non-small cell lung cancer. The other big utilization of liquid biopsy in non-small cell lung cancer is picking up these rare mutations. Especially if a patient has progressed, it is definitely worthwhile to try and look for these rare mutations. Now, the BRAF is a rare mutation which can potentially get picked up. BRAF plays a very important role in the RAS-RAF-MEK-ERK pathway. The MAP kinase pathway is somewhat like this, and you can see that the upstream part of it is the KRAS, and then downstream we have BRAF signaling, MEK, and the MAP kinase pathway. So MAP kinase pathway regulates cell signaling from transmembrane growth factor receptors, leading to cell proliferation, and BRAF mutations result in constitutive BRAF activation and uncontrolled signaling via the MAP kinase pathway. So BRAF mutations occur in about 1 to 4% of all non-small cell lung cancers. I myself in my practice have not been able to pick up a BRAF mutation in lung cancer, but I do test each and every patient for BRAF mutation. BRAF mutations typically do not overlap with other common mutations in non-small cell lung cancer. So it's important that if we have picked up a BRAF mutation, then it's very unlikely that the patient may also have other mutations like KRAS, EGFR, or ALK mutation. So in contrast to the other oncogenic drivers in non-small cell lung cancer, key patient characteristics or indicators have not been well characterized. So this is another important thing that we need to look at, is that we cannot label a patient as saying, okay, this patient may probably have BRAF mutation, so let us try and test for this. So it is important that in all patients, we should try and test for this, because we never know in do not appear to correlate strongly or smoking status. Some studies point to these mutations being seen in patients with a history of smoking, but that cannot be taken for granted. The biggest, the most important type of BRAF mutation which can be identified as a V600E mutation, and this constitutes nearly 56.7% of all BRAF mutations. We have a drug today which is available in India, which we can use in the first line treatment of BRAF mutant non-small cell lung cancer patients. This is a combination of dabrafenib with trametinib, which targets the different kinases in the MAP kinase pathway. We have the dabrafenib, which is a reversible, potent, selective inhibitor of RAF kinases, including BRAF V600 and particularly BRAF V600 and the V600K mutation. And then we have trametinib, which is a reversible, highly selective inhibitor of MEK1 and MEK2 kinase activity. The rationale for combining dabrafenib with trametinib is that we are able to target multiple portions of the MAP kinase pathway, which may help us overcome any resistance which occurs anywhere in this pathway. So in non-small cell lung cancer and melanoma, compared with BRAF inhibition alone, BRAF and MEK inhibition has been shown to be more effective. These are all the trials that we have on BRAF pathway mutation and targeted therapy in this particular subset of patients. We also have vemurafenib, which was the first available BRAF mutant targeted therapy, but it's not currently available in India. Most of the data that we have is phase 2, because essentially these mutations are so rare, so very rare in our patients with non-small cell lung cancer, that phase 2 data of about 100 patients is more or less enough to come up with clinical recommendations. So dabrafenib and trametinib was assessed in a phase 2 study, and it was proven that this was more effective than dabrafenib alone in patients with previously treated BRAF V600E mutation. The overall response rates and the PFS nearly doubled over here. When we looked at patients who were treatment naive, again in that scenario, dabrafenib and trametinib had a significantly better overall survival and PFS as compared to standard of care chemotherapy. So DCGI has approved the indication of dabrafenib with trametinib in patients with non-small cell lung cancer who have a BRAF V600 mutation. The other very rare mutation that I'm going to be touching on is the MET exon 14 skipping mutation. This is again something which we can potentially pick up on a liquid biopsy, purely because MET mutations is reported to be mutually exclusive of other mutations, and MET mutation, the splice site leading to exon 14 skipping mutation, result in the gain of function alterations. This occurs in about 3% of all patients with non-small cell lung cancer, and these are linked to early stage diagnosis and patients with an older age. So there was a retrospective study of about 150 patients in whom, if a MET inhibitor was used, this prolonged overall survival compared with those targeted with other therapies. So OS in MET mutated stage 4 non-small cell lung cancer patients was about 8.1 months for patients who never received a MET TKI. In fact, it was about 10.5 months for patients with MET mutation only, and about 5.2 months for patients with MET mutation and other concurrent mutations. We have a selective MET inhibitor called capmatinib. This was recently approved and available in India in the past 1 year or so. This is an oral ATP competitive, highly potent, selective and reversible inhibitor of MET kinase. This is shown to cross blood-brain barrier, and this leads to potent blockade of MET activation and in cell-based functional and biochemical assays, as well as in vivo models. So compared with other agents, capmatinib is the most potent inhibitor available against the MET exon 14 skipping mutation. The pivotal trial which looked at the which looked at capmatinib was the Geometry Mono 1 trial. This was a phase 2 trial with multiple arms over here. The primary inclusion criteria was patient should be EGFR wild type and should have MET dysregulation, and it should include patients with MET exon 14 skipping mutation. If we see over here, if capmatinib was used in the first line, nearly 66.7% patients had a response to capmatinib, and about 98.3% had some kind of a disease control when used in the first line therapy. When we use capmatinib in third line therapy, then the response rates again had increased from to about 50% and 40% in these particular settings respectively. There was a clinically meaningful median overall 6 months in second, third line, which was observed when capmatinib was used. It's already available at least on compassionate basis, and about 2% of patients with non-small cell lung cancer have RET mutations over here. Hello?
Yes, sir, we can hear you.
Yeah. Okay, so about 2% of patients with non-small lung cancer have RET fusion mutations. The pivotal trial again used over here is the Libretto 001 trial, which looked at about 100 patients with RET fusion mutation. Again, in this, we have about 85% of the patients who had a response to treatment, and about 60% had a response which lasted for longer than 6 months. So to sort of summarize my talk and look at what is the way forward, liquid biopsy has a definite role at diagnosis and at prognosis. This can potentially be used to monitor treatment. A follow-up, this can also be used as a follow-up tool post first-line therapy for early detection of relapse, but we are not yet there clinically. I know there is a lot of data, a lot of trial going on for this, and a lot of data is being generated. The biggest pitfall with liquid biopsy is going to be a false negative rate, and this need to be brought down significantly. Indiscriminate use without phase 3 data or approval from regulatory authorities and good quality control has to be done if the use of liquid biopsy has to increase in clinical study. I thank you all for a patient listening, and I stop my talk over here.
Thank you so much, Dr. Murli. It was a wonderful session indeed. So our next speaker is Dr. Krupa Shankar, who is Director and Consultant Med Oncologist, NSR Cancer Center, Coimbatore. Dr. Krupa would be talking on approaches to molecular testing in non-small cell lung cancer. Over to you, Dr. Krupa.
I hope my slides are visible and I'm audible. So a very good evening to everyone, and at the outset I'd like to apologize for the technical glitches. I had a few connectivity issues. So the next 15 or so minutes I'm going to take you through the role of molecular testing in non-small cell lung cancer with a special focus on the role of CTCs and liquid biopsies from a clinician's perspective. Now, how do you actually translate that into practice? So I'm sure we've heard from Aditya as well as to how we've come a long way from just histology-driven therapy to the current era where we're talking about driver mutation and targeted therapy, where we know it's all about precision medicine and personalized therapy, where one size definitely does not fit all. So we talk about mutations that are both identifiable as well as targetable. So it's no longer just about picking up a mutation that's identifiable, but you'll also have, we know that there are targetable driver mutations and other mutations which we don't yet know how to target. So the commonest mutations are obviously read by KRAS, then followed by EGFR, ALK, ROS1 in that order. And if you look at the current NCCN recommendations as well, we have around 9 biomarkers which are absolutely essential for us, for anybody with the diagnosis of stage 4 non-small cell adenocarcinoma lung. So with that background, we'll move into how we actually go ahead and get the biomarker testing done. So we always keep talking about tumor heterogeneity between the primary site and the metastatic site. So, and we know that bone metastasis is one of the most common sites of metastasis for non-small cell lung cancer. So a bone biopsy, obviously, we know that it's very suboptimal because the yield is likely to be much lesser. Decalcification tends to be an issue, and degradation of DNA also tends to be another issue, which is why bone biopsy is definitely not a preferred option. So ideally, always the primary site is preferred. And in case it's inaccessible, or if it's not, if the patient cannot get it done, then you could actually rely on getting it from the metastatic site. And again, you always send for EGFR, ALK, BRAF, MET, RET, NTRK. You can add all of those biomarkers, which needs to be sent as a broad panel. And the advantage, I'll talk about the advantages of doing a broad panel as opposed to doing a reflex testing each way. So you would definitely want to consider it in patients with adenocarcinoma, never smokers, or if you have a mixed histology as an adenosquamous histology, or if the specimen is very small as well. And again, we know that with an NGS, the key, obviously, probably the major advantage is that you're able to run through all of these tests at one go. And otherwise, when you do it sequentially, you're likely to run out of tissue at some point in time. So you may not be actually able to do all these biomarkers. So setting the context, actually, what do you mean by when you talk about the concept, or what do you mean by a liquid biopsy? So these are basically DNA which is shed from the tumor. So that's why they're called circulating tumor cells or cell-free DNA. And we know that tumors that arise from different parts of the body, the amount of DNA that can be shed from these sites are different. For example, liver, obviously the amount of DNA that's shed is much higher as compared to the peritoneum or even the lung, in that order. So yeah, definitely there also is tumor heterogeneity, but in a way, CTCs would actually help in overcoming the tumor heterogeneity, because if you look at, as I am going to take you through the rest of the biomarkers, I'll tell you why, because probably an RNA-based NGS is probably considered to be the gold standard for a lot of other biomarkers which we actually run in practice. So again, when do we actually use it? Can it be used as a standalone for diagnosis? No, that's not where it is approved, but it's used as a complementary diagnostic testing. When we talk about diagnostic testing, we always talk about companion diagnostic testing and complementary diagnostic testing. So this is a complementary diagnostic testing where you can run through the entire panel of markers, and especially if where we know tissue is an issue and if we cannot actually get hold of the primary. And again, the advantages are is definitely minimally invasive and can help overcome the major issue of tumor heterogeneity. Limitations are the sensitivity and the specificity, and I'll show you a little bit about that as we move along. And again, the other key thing to remember is a negative result. If you have a negative result on liquid biopsy, that doesn't mean that the patient could still have a positive biomarker. So you would still have to go ahead and get a biopsy from the primary. So let's look at probably the differences between a single gene versus a multi-gene testing. The single gene testing, I know, like having said all of this, probably in practice, most of us will still do that based on PCR platforms, and also because we earlier had these coupons where patients would actually be able to get it free of cost as well. But again, the limitations are about the tissue sample, and then again, the need for repeat biopsies as well. Multi-gene testing, obviously, tumor tissue is never going to be an issue. You can actually run through multiple biomarkers. So cost definitely is an issue here, because obviously we still haven't made it very cost effective. And again, the other issue is about choosing the right platform and the methodology, and again, the bioinformatics as well. So, and it's definitely not very easy to do that in community practice, outside of an institution or outside of an academic practice, that is. So this was the NILE study, which stands for non-invasive versus invasive lung cancer evaluation. So this was a very large study which looked at a head-to-head comparison between a liquid biopsy versus tissue biopsy. So what the key findings from this study were that you had a concordance rate of more than 90% for these key 4 biomarkers, EGFR, ALK, and ROS, and BRAF. This was based on the Garden 360 assay, which is an FDA-approved assay. So this is how it went. So look at the number of patients that were able to be picked up by using the Garden 360. You could test more than 95% of patients for all of these biomarkers, including EGFR, ALK, ROS, BRAF. Whereas when you look at doing it sequentially, one after the other, by the time you reach your BRAF, you see that you're able to run through only around 35%. So I think that's the issue with doing it on tissue alone. And again, the turnaround time was much quicker by doing a Garden 360. It was 9 days as opposed to 15 days, about a week earlier with Garden 360. And again, you could end up picking more patients with biomarkers. For example, 90 versus 70, those were the ballpark figures. So moving on, let's look at how do we actually put that into practice. So when we talk about biomarker positive non-small cell lung cancer, especially targetable driver mutations, we talk about EGFR, which we've heard from Aditya already, ALK, ROS1, BRAF, and NTRK. And on progression, we talk about doing a T790M mutation, and if that's positive, then you start them on osimertinib. So since Aditya has already covered all of that, I'm not going to be touching again on EGFR. I'm going to move on and talk a bit about ROS. So we know ROS, obviously the gold standard still remains FISH. You have to do a FISH testing for ROS to actually confirm ROS1. And let's look at all these ROS inhibitors that have been used. So crizotinib, ceritinib, and lorlatinib, they are multikinase inhibitors. They also have an action on ROS1. Entrectinib is a very specific ROS inhibitor as well, apart from inhibiting the NTRK as well. So in the first line, we know both crizotinib and entrectinib are options. And at progression, again, lorlatinib is an option in the second line setting for somebody with a ROS1 positive or driven non-small cell lung carcinoma, adenocarcinoma lung. And the response rates, again, especially with entrectinib and repotrectinib, which are actually NTRK inhibitors as well, the response rates are much higher, and CNS penetration also tends to be much higher with those drugs. So let's again look at BRAF, and the other key thing about BRAF is this particular mutation, which is V600E mutation, which usually is seen on exon 15 followed by exon 11. These are the most common exons where you get to see the V600E mutation. And again, the rationale behind why you'd want to combine a BRAF and a MEK inhibitor is important as well, because you have to look at blocking the downstream signaling pathways as well. Because only by blocking the BRAF, there is going to be increased MEK overexpression, which can actually predispose to us developing squamous cell carcinomas of the skin. So which is the rationale as to why you combine both together. And remember now that BRAF has got a tumor agnostic approval as well. We are in the era of tumor agnostic approvals, meaning I'm sure pretty soon down the line we'll all be ending up treating patients based on just tumor agnostic approvals. Because as of right now, we know having a high MSI, TMB high, and NTRK fusions, and now BRAF as well, all of these are tumor agnostic indications. I'm pretty sure down the line, RET also is likely to become a tumor agnostic indication. So let's look at the phase 2 data, which actually led to the approval of dabrafenib plus trametinib. You had cohort A, which was a BRAF monotherapy, and then cohort B, which was dual BRAF plus MEK inhibition, and cohort C in prior untreated patients. As you can see, the PFS ranged from 5 to 10 months. In the previously untreated cohort, it was around 11 months, duration of response being close to 10 months. So let's again look at the other tumor agnostic indication, which is NTRK fusion positive solid tumors. Again, given that the entire incidence is going to be less than 1% in all solid tumors, but given how they looked at it in a basket study, you could see that majority of these patients were patients who had sarcomas followed by non-small cell lung cancer, around 20%. So again, if you look at it, entrectinib not just has an action on ROS1, but like I said earlier, it does act on the NTRK, the neurotrophic tropomyosin receptor kinase fusion positive solid tumors. So pretty impressive response rates here seen as well, especially in non-small cell lung cancer. So if you look at the PFS, again, you're talking about a median PFS of 11 months and overall survival of close to 24 months. And the key thing again was the intracranial efficacy in patients with CNS metastasis as well. It seemed to do very well. And what about the other NTRK inhibitor, which is larotrectinib? And again, this was the data set which looked at across the board in a lot of solid tumors, and including non-small cell lung cancer as well. And as you can see from the waterfall plot here, that the response rate is pretty impressive, irrespective of patients who had brain metastasis or without brain metastasis. The response rate is to the tune of about 70%. So I'm going to quickly take you through how do you look at targeting RET, MET, and the KRAS. Do we have, can you actually target the KRAS mutations as well? Because like I said earlier, that's one of the most commonest mutations that you get to see in non-small cell lung cancer adenocarcinoma. So can you target that? And what about HER2 and EGFR exon 20 mutations? So I'm going to quickly take you through that. So these are how RET fusions, as we call them, receptor tyrosine kinases, RET fusions actually look like. And the incidence is only around 1 to 2%. And also, and we've heard about, we know that they happen much more commoner in papillary PAPCA carcinoma thyroid. And so the RET fusions, obviously you'll have to do a NGS, a DNA-based NGS. But again, the gold standard or the pickup rates tend to be much higher. Sensitivity and specificity also tends to be much higher with an RNA-based NGS. So that's the gold standard. So these are all the various methods as to which you could actually look at doing a RET fusion. And like I said earlier, the RNA-based NGS still remains the gold standard because they're able to obtain information regarding the fusion partner gene as well. So what about RET inhibitors? Well, we have a host of RET inhibitors. The most selective RET inhibitors are selpercatinib and pralsetinib. So both these drugs are already approved as well, based on the libretto study and the arrow study. Cabozantinib and vandatinib are basically, they are multi-kinase inhibitors. They do have an action on the RET as well. So these are the studies that I was talking about, which led to the approval of selpercatinib and pralsetinib. So these were basically phase 2 studies, looked at responses and the duration of response. So if you look at the safety profile, again, with as a class adverse effect with RET inhibitors, I think the key grade 3 adverse event was more of hypertension. And again, hypertension and neutropenia seem to be predominant. And all the other grade 3 adverse events were less than 5%. So I think we're done with the era of older multi-targeted RET inhibitors like cabozantinib and vandatinib. We've welcomed the newer RET specific agents like selpercatinib and pralsetinib, which we know have much lesser off-target side effects. They have higher response rates, CNS activity, and a much favorable toxicity profile. So, and like I said earlier, this is also working towards a tumor agnostic indication. I'm sure we'll have that approval pretty soon as a tumor agnostic indication. It's already approved for RET fusion positive non-small cell lung cancer, even the first line. And an RNA-based NGS is the gold standard if you're looking at testing for RET. And again, now moving on to MET or CMET, MET amplification or MET exon 14 skipping mutations. So again, when you talk about MET, you could have single nucleotide variants, amplifications, exon 14 skipping mutations, or fusions as well. So I think we now know that for exon 14 skipping mutations, we have an FDA approval. The trial also did look at amplifications, but then again, that the primary endpoint was not that. So when you look at the incidence, it's around 3 to 4% in adenocarcinomas of lung, more commonly seen in sarcomatoid cancers. And again, you have to do an NGS, and an RNA-based NGS is probably the gold standard with higher sensitivity and specificity based on that. So that's in a nutshell as to how you would actually look at testing for a MET exon 14 skipping mutation. An RNA-based NGS is the gold standard for doing that as well. And probably this is another reason as to why I'd probably said a broad-based RNA, both a DNA and an RNA-based NGS, probably will help us pick on all these other targetable driver mutations as well. So when you talk about inhibitors, we know they are type 1, type 2, and type 3. So what do you mean by type 1? They actually actively and competitively bind to the ATP binding pocket. So again, examples for that are type 1 is crizotinib, and type 1B are capmatinib and tepotinib, and savolitinib, which are actually much more selective MET inhibitors. Crizotinib has action on ALK, ROS, and MET1 as well. So it's more like a multi-kinase inhibitor. And again, type 2 inhibitors, they also bind in the inactive state as well. And cabozantinib and glastonab are examples for that. And type 3 are basically allosteric dual inhibition of both the alleles. And tilvantinib is an example for a type 3 MET TKI. So let's look at the approved MET inhibitors. Crizotinib, it's an off-label option in MET exon 14 skipping mutations. Tepotinib has been approved, and capmatinib has already been approved as well. So these were the key trials which led to the approval of these MET inhibitors. Crizotinib was approved based on the profile study, where we looked at the median duration of response of 9 months and a median PFS of 7 months. Capmatinib, again, based on the geometry 101, which Aditya also alluded to. And again, you can see that the median PFS is 9.5 months. And tepotinib, importantly, this is where they looked at using liquid biopsies to pick up MET exon 14 skipping mutations as well. And the concordance rate was on par with what was done from the tissue biopsy. So that probably is a key finding from the VISION study, which looked at getting an approval for tepotinib, and that got approved as well. And savolitinib is not yet gotten approved, and when you look at the safety profile for all these MET inhibitors, peripheral edema seems to be the major concern, as you can see here as well, that more than 5% of grade 3-4 adverse events, edema seems to be a major concern. So again, just to summarize on MET exon 14 skipping mutations, crizotinib was the earliest generation of type 1 basically MET inhibitor. We have now more access to more selective MET inhibitors. Capmatinib and tepotinib are both FDA approved options, and getting an RNA-based NGS is the gold standard for doing an exon 14 skipping mutation. Well, moving on to KRAS. KRAS, like I said earlier, most common mutation that you get to see in stage 4 non-small cell adenocarcinoma lung, and almost more commonly seen among smokers. And out of these KRAS mutations, the G12C mutation is the most commonest one as well, accounting for 13%. And we now have drugs that are capable of working on this, particularly the G12C mutation, which are both sotorasib and adagrasib. So again, when you look at characterizing them, like I said earlier, 40% will fall into the G12C, and the non-G12C will be the rest of the 60%, followed by G12B and G12D in that order. So these were a couple of KRAS G12C inhibitors that I was talking about, sotorasib and adagrasib. So sotorasib has now got an FDA approval for KRAS G12C, not in the first line, but post progression on a platinum-based doublet, you could use it in the second line setting. Adagrasib is not yet approved. And these were the results from the code break study, which led to the approval of adagrasib. Sotorasib, sorry. Again, the response rates to the tune of 20%, and disease control rate of 80%, and then the crystal study, which led to the approval of amylase. It's not yet gotten approved, but still, adagrasib is likely to get an FDA approval pretty soon. The response rates, again, pretty stunning, 40%, which is much better than the code break data, and the disease control rate, 100%. But again, remember, take it with a pinch of salt. It's only phase 2 data and a single cohort phase 2 data. So let's look at EGFR exon 20 insertions. We know that when you talk about EGFR mutations, exon 18 to 21 are common, but we know that not all of them are actually explicitly sensitive to TKIs. So exon 20 insertion is considered to be a resistant mutation, and which is why our conventional EGFR TKIs are ineffective in this particular population. So it accounts for about 4 to 10%, and we did not have any approved targeted therapy until recently. So now we have a couple of agents that are approved in this setting as well. One of them is mobocertinib, which is an oral selective dual HER2 TKI based on the XCLAIM trial, which led to the approval of mobocertinib. And then we have amivantamab, which is a bispecific monoclonal antibody directed against EGFR and MET, which has also gotten approved in the same space. So those are the two drugs that have gotten approved, mobocertinib and amivantamab. Amivantamab based on the chrysalis study, and poziotinib, well, we had a lot of promising data, but unfortunately it did not see light at the end of the tunnel and did not get approved. So again, this is just from an update from ASCO, which led to the approval of amivantamab, which I was just talking to you about earlier, based on the chrysalis study, especially in EGFR exon 20 insertions. Post progression on platinum is where it's gotten approved based on a response rates of 36% and a median PFS of 8 months. So again, to summarize, exon 20 insertions, platinum-based doublet still remains standard of care in the first-line setting, and post-progression, mobocertinib and amivantamab both are options. Mobocertinib is a completely oral option, and amivantamab is a bispecific monoclonal antibody targeted against EGFR and MET. So probably getting on to the last aspect of the talk, which is on targeting HER2 as well. In HER2, so can you actually do that even in stage 4 non-small cell lung cancer? What about targeting HER2? A pretty exciting data again from this antibody drug conjugate. We know this is making a lot of waves everywhere. The trastuzumab deruxtecan as a drug T-DXd already gotten approved in breast cancer as well. So this was a study looking at patients who had HER2 positive non-small cell lung cancer who were refractory to standard therapy, and look at the response rates. I mean, like, the response rates based on the waterfall plot, pretty impressive. Median duration hasn't been reached, median PFS of close to 14 months in a heavily pretreated population. So seems to be pretty promising. Currently not yet approved as of say. So, probably before I conclude, I'm going to just leave you with this image. This is how it stands as of right now. We know that we have drugs for all these mutations that are actually not just identifiable, but also targetable driver mutations, starting with EGFR, ALK, RAS, BRAF, NTR, GRET, MET exon 14, and in the HER2 and EGFR exon 20 insertions as well. So with that, I think I'll conclude, and I'll be happy to take any questions if there are any.
Thank you so much, Dr. Krupa, for the wonderful session. Now we will move on to our question and answer session. So there's a question that, is it possible to do fusion genes through liquid biopsy? Yeah, it is possible. Dr. Krupa, would you like to answer this? You must be placing a requisition for the patients for this
Yeah,
particular.
definitely. So, yeah, it definitely is. The answer to that question is yes. You can definitely look at fusion genes through liquid biopsy. I mean, like, depending on whatever test that you're ordering for, be it the Foundation 1 assay or the Garden 360, yeah, definitely you could look at the Oncquest platform or any of those. Yeah, it is definitely, you can look at single nucleotide variants, you could look at insertions, you could look at deletions and gene fusions as well. So, yes, it's definitely possible to look at fusion genes and the partner genes through liquid biopsy, yes.
Now we move on to our next question. Himanshi, can you move on to the next question, please? Yeah. So, anyone doing RNA fusion genes in biopsy? So, Dr. Krupa, again, I'll request you to answer this question.
Yeah, sure. Like I said earlier, yes, there are doing even our, I mean, like, I mean, without taking names here, there are a lot of companies here which actually do an RNA fusion gene as well. RNA sequencing is being done. So when you talk about sequencing, it is not just DNA sequencing. There are a lot of, commercially available NGS panels that look at both doing an DNA and an RNA sequencing as well. So RNA sequencing also covers these fusion genes. So yes, definitely yes, it's being done.
So next question is, are you using a liquid biopsy for monitoring of disease? So anyone out of you, anyone would like to answer?
Sure, if Aditya is around, probably I'll invite Aditya, are you there? If you're there, you can take that or I'll take that.
Yeah, I am around. So essentially for disease monitoring, this is not yet entered public domain or clinical day-to-day clinical practice. So it's very important for us to, do what has been approved or what is been, stood the test of time when we talk about disease monitoring status. So I don't do it in that scenario, but I'm sure if you ask me this question in a couple of years, my answer might change.
Dr. Krupa, would you like to mention something on this?
Yeah, sure. I mean, like, recently also we had our own, DCGA approving CTCs as well. I mean, like, again, without taking names, I'll take that name on for Discover. CTCs, yeah, I mean, like, probably like Aditya was rightly pointing out, probably is an excellent way to look at monitoring for disease, especially if somebody's got residual disease, or if you want to give them a response adapted therapy, do want to put them on maintenance, duration of therapy, all these questions are likely to be answered with that. But like we said, we don't have a standard value, and it cannot be just done at one point in time. You cannot decide on it based on just one value. So you'll have to keep serially monitoring it over a period of time before we actually draw meaningful conclusions from using CTCs for monitoring and for treatment escalation, but de-escalation as well. But having said that, exciting times ahead because DCJ has already approved these CTCs, and now we have commercially available tests, again Indian-based tests as well, that are being done. So yes, you can do it.
So the next question is, do you prefer to do only EGFR or comprehensive panel when you send for biopsy, molecular testing? So Dr. Aditya, would you like to?
Yes. So,
yeah.
So, can you repeat the question, please? You're asking whether it's a comprehensive panel, is it?
Right. Would you like to prefer to do only for EGFR or comprehensive panel?
I think that that question has been answered quite vehemently in the last year or so. Given the fact that there are so many other fairly rare mutations and so many actionable mutations available, it is going to be a panel every single time.
Right.
Ma'am, that was the last question.
Yeah. Thank you so much. So on behalf of Oncquest Laboratories Ltd, I would like to thank both of our speakers for an enlightening and enriching session. As you may be aware that Oncquest is a leading diagnostic player when it comes to specialized testing. We have a pan-India network with over 20 years of experience in specialized testing. And we believe in continuous knowledge sharing and education and remain committed to providing the best-in-class support to clinicians. So once again, thank you so much for all your support. last but not the least, thanks to our team marketing and Kavina for excellent coordination as always. Thank you so much. Have a wonderful evening.
Thank you.
Thank you,